Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Number 30 of this webinar series that was started earlier in May of 2020, and it's been an interesting time. I've learned a lot, and we're hoping to continue to the end of December every weekend. And we have been blessed to have many presenters from around the world. Tomorrow we're going to have Dr. Tiago Veras all the way from Brazil, and we're going to have Dr. Tiago, two Tiagos tomorrow, Tiago Caramelo from the Malo Clinic in Portugal. Today we have the privilege of having Dr. Lyndon Cooper. I'm going to read his bio and he's going to take it away. Yeah, Dr. Lyndon Cooper is an expert in orofacial and dental rehabilitation and oral biology. His research is patient-oriented and focuses on advancing the areas of bone biology, adult stem cell bone regeneration, the clinical evaluation of dental implant therapies to improve patient care. Dr. Cooper earned his dental degree from the New York University, and he has a Ph.D. in biochemistry from the University of Rochester. He earned his certificate in prosthodontics from the Eastman Dental Center and completed a fellowship in the National Institute of Dental and Craniofacial Research. Prior to joining the University of Illinois at Chicago, Dr. Cooper served on the faculty at the University of North Carolina. He's currently Assistant Dean for Research. Am I right, Dr. Cooper?
Close enough.
Okay.
Yes.
All right. Thank you so much. It's a privilege to have you here. And please, I'm going to stop sharing my screen. Please take it away.
Let's see if I can get to share screen here. Yeah. Let's see. Hopefully we're here.
Yes.
Great. Well, Uvo, thank you for the invitation. And I can't tell you how thrilled I am to join this wonderful Helping Hands program because, first of all, I've never gotten to Africa. It's a continent that I have not shared meals, friendship, or education with. And this is really an honor for me. And it's a very strange time we're in. And I wish everybody the best of health and well-being during these COVID times and remind you all to wear your masks and stay safe, please. I've been teaching prosthodontists for nearly 30 years, and one of the biggest challenges has been teaching aesthetics. And I believe that aesthetics is more fundamental than people are willing to give credit for. And if we can objectify aesthetics, we can improve our discussion with our patients, we can improve our communication with laboratories, and we can simplify treatment by providing appropriate aesthetic outcomes without multiple try-ins. So what we wanted to do today is spend the hour with you talking about some fundamentals, some things you may know, but then hopefully getting to the end where we can apply this for you. I need to make this go forward. So the first thing is that we have to have some foundational knowledge. And the biology behind all of this, we don't have time to talk about. For example, periodontal and odontogenic health. Without deriving your patients to a position of good periodontal and odontogenic health, we can't begin to discuss aesthetics. In addition, without appropriate occlusal conditions, we cannot improve aesthetics. And in the general practice world in the United States, one of the greatest crimes in dentistry I see are people treating anterior teeth without addressing posterior tooth problems. What I'd like to do most importantly today is give you a framework for providing your patient with a comprehensive aesthetic diagnosis. And you'll see how this comes together. Once you have those foundational issues, then all the things you learn in dental school you need to put together: appropriate tooth preparation, excellent tissue management, the technical skills of milling and ceramic finishing today, and One thing that we probably will not even get to mention today are the technical issues in terms of aesthetic cementation. But when you put all these fundamentals together in your practice, you end up with a very, very rigorous and structured way of doing work. Now, when you put it all together, you can start with this young lady who was born with tooth agenesis, and with 6 anterior veneers and some implants, we can derive a beautiful result, as you see here. It's actually very simple. The whole case was done in only 4 visits, but it was based on knowledge of tooth form, tooth anatomy, biology, anatomy, and really a good orthodontic arrangement of the teeth, followed by very simple implant placement, tooth preparation, and delivery of a full mouth of ceramic restorations to derive at this aesthetic outcome. You know, it was said by Frank Spear, someone whose name you know very well, that if the sequence planning procedure, proceeds biology to structure to function and finally to aesthetic, the eventual aesthetic outcome may be compromised. And you really have to think about the order in which you do this. And I can't underscore the importance of understanding biology, structure, and function before one reaches the point of aesthetics. Unfortunately, we don't have hours to discuss how these impact aesthetics. One of the things that I believe in is that most of us who are taught aesthetics are so laser focused on tooth-related issues. In dental school, we study the white thing. Tooth. We always look at the white thing. We taught on the typodont to prepare the white thing and to restore the white thing. It's the tooth. But quite honestly, the biggest failures in aesthetics are bigger issues. And so we use the phrase MVP, right? And it's midline, vertical dimension of occlusion, and occlusal plane. For comprehensive aesthetics, if one does not establish and maintain the midline, the vertical dimension of occlusion, and the occlusal plane, any aesthetic outcome will be compromised. And so each of these 3 things, midline, vertical dimension of occlusion, and occlusal plane, must be assessed first and established before beginning any of the other things we'll be speaking about today. This is so important in our dentures and our large implant reconstructions that are so popular today. And I see them confused and misused and abused over and over again. And it's very frustrating to see a technically beautiful reconstruction cemented with a midline deviation or a occlusal plane variation that makes the case unsuccessful. Now, it's very simple, as you can see here. This is a comprehensive case with full mouth reconstruction on implants. And what we've done is, in the digital world, we've placed the teeth where they belong. And now you can see that when we understand where the midline, where the vertical dimension of occlusion is, and where the occlusal plane is, we can begin to establish tooth positions in a computer simulation that allows us to begin our aesthetic reconstruction. These big picture items are so important that as we gloss through everything else today, I was afraid that we'd miss these important points. And so I ask you to keep in the back of your mind, when you first meet the patient, you have to establish the midline, the vertical dimension of occlusion, and the occlusal plane before going further. You should ask yourself, are these in ideal locations? Occlusion is next. You know, so often patients come to us with altered tooth positions in the anterior segment. And many times the spacing of anterior teeth, movement of anterior teeth is caused by an occlusal discrepancy or the loss of posterior tooth contact. This gets back to one of the 3 principles in MVP, but a reduced vertical dimension of occlusion or a collapsed bite leads to the alterations we see here and cannot be restored unless we actually orthodontically move teeth, prosthetically move teeth into their original position, and that requires the reestablishment of the vertical dimension of occlusion. I am, by the way, not at all concerned about altering the vertical dimension of occlusion in my rehabilitations. Let's see if we can move this slide forward here. So what you see is when you have these alterations, you have these large changes in dimensions, which are often asymmetrical. And so replacement of a lateral incisor in this position could create quite a asymmetry when considering the size of the lateral incisor. And now you see the lateral incisor and the central incisor are the same dimension, and this central incisor is encroaching on the space where the lateral is. I can go on and on and on with these many problems. So this patient presented to my clinic as a person who had had crowns placed by a student. And she was very disappointed with the aesthetics because of what she thought she was going to receive. You can see that she has history of a functional discrepancy, and she's missing posterior teeth. So as we look at this, you can see that, yes, there are problems with the restorations, but she's disappointed. And it's also very funny that this lateral incisor is actually built completely backwards for the space, but that's neither here nor there. But you can see the large spaces that have been created. And she came to the clinic because the clinic decided that this single implant was non-restorable. They had not accounted for the aesthetics. They had not accounted for the vertical dimension. So what we did is we reconstructed her at a new vertical dimension of occlusion, and we're able to create this aesthetics for her, which was very pleasing. But it could not be done without posterior restorations. So you can see that we have established an occlusal plane. We are going to have to create occlusal contacts with new crowns, and we're going to have to deal with the attrition that was related to what we say in the United States, tooth 22 and 23, or in Europe, I guess it would be 3.2 and 3.3. And so you can see that what we've had to do is we've had to establish a new posterior occlusion by not offering the patient what she requested, which was an anterior aesthetic restoration, but a comprehensive restoration, which required her to have additional implants placed and posterior fixed dental prosthesis. The result, however, is, establishing the appropriate occlusal context and being able to create crowns of the appropriate dimension and aesthetics, which also required attending to the lower arch, which required 2 veneers on tooth number 3.2 and 3.3, as well as 2 premolar crowns to establish occlusion. What we ended up with is a completely different view of the world. And you can see very nicely that we've gone from her unesthetic view, which she was very disappointed with in the clinic, to a very attractive aesthetic result with anterior crowns, posterior implant-supported occlusion, a premolar crown, 2 veneers, and another premolar crown in the other arch. It's unfortunate that we got this far along the way, but we did not stop to think about the fundamentals. Now, much has been written, and I wanted to pay homage to some work that was done by Morley and Eubanks. This is a very important paper on the macroaesthetic elements of aesthetics. And they say that this represents the relationship of different ratios of multiple teeth to each other, teeth to soft tissues, and teeth to facial aesthetics or facial characteristics. And facial aesthetics are related to how the lips and soft tissues frame the smile and speech, smiling and laughter. They speak about gingival aesthetics as being the health and architecture of the pericoronal tissues. And I think the architecture of gingiva is so underrated. And our general dentists today don't use periodontal expertise as often as they should in recreating a smile or even providing a single unit crown. Microaesthetics is the anatomy and character of individual teeth, and it plays a very small part in smile design or aesthetics. And in fact, it's what we learn in dental school. And macroaesthetics is the relationship between the anterior teeth and the surrounding tissue landmarks. And this is the part that I think we often fail at, and it has a lot to do with what I've mentioned before in terms of gingival aesthetics. So what they did is they talk about, again, these 4 key points: facial aesthetics, gingival aesthetics, microaesthetics, and then macroaesthetics. And it's a very good way to conceptualize what you're dealing with. Now, if we think about macroaesthetics and how the teeth relate to soft tissue form, there are some guidelines. But in general, what we want to do is we want to put the teeth in the middle of the head. And we want the midline to be related to the middle of the face. Now, you can see here in this picture that the midline is not coincident with the philtrum. But if we were to step back, we'd see that this is an appropriate place for her smile. We also notice that the tooth size is coincident with the size of her face. The arch fills her smile, leaving a small corridor. These are the things that we think about. Tooth display relative to the lower lip line shows the barest amount of gingiva above the teeth, showing all of the dental papilla upon a bright smile. This is what we consider today to be perhaps an ideal appearance. We can speak more to this at a later date. So when we think about the facial midline, incisal embrasures, connectors, axial inclination, shape progression, and tooth display or reveal, these are the components that Morley and Eubanks attribute to macroaesthetic design. And of course, I'm leaving out the smile line, and which we've talked about vestibular space or framing. So when we think about the midline, as I mentioned, it may be very difficult to identify. And this is an actually beautiful smile centered in the middle of the face, but again, it's not actually centered on the center of the nose. The teeth should be parallel with the midfacial axis and should be approximate the midline. Orthodontics have argued that patients don't notice up to a 2 millimeter discrepancy and a 6-degree orientation. But I find that patients do notice even the smallest discrepancies of midline and the smallest axial orientation. We should be very careful about trying to make these issues as perfect as possible. Incisal embrasures, the dimension of the incisal embrasure increases with distal position, and this is really important to following the smile line. Connectors are very well described. Stephen Chu has done some work here, and what you see is the connector height is actually aligned with the embrasures. And this is a beautiful example of seeing the embrasures getting larger as we go distal. And you can see the connector height is 50% of the tooth dimension, which suggests that the other half of the tooth dimension is gingival contour and gingival architecture, suggesting how important, again, gingival health is. As we move to the lateral incisor, it's 40% on the mesial. And as we move to the canine, it's only 30% of the mesial. And oftentimes canines are very long and look inappropriate. If one is wishing to put any dynamic character or youthfulness into a smile, one must deal with these gingival embrasures as the key component here. Axial inclination, as you can see here, there's a dynamic smile here, and the axial inclinations of all 6 anterior teeth are not parallel to one another. You can see this lateral incisor has a flare to it, but given the character of the teeth, it actually works very nicely for this very beautiful smile. None of these teeth are actually parallel with one another, but what you can see is there's relative symmetry between the canines, between the laterals, and between the central incisors. This symmetry of axial inclination is a very strong tool for you to use in deriving strong aesthetics in your design of a smile. Shade progression is also important. We know that it is often very challenging to give someone their beautiful A1 or B1 smile in a C2 or a B2 dentition. One of the tricks we use is shade progression, and you can see it very nicely here, moving from a B1, maybe to an A1, and maybe to even a D2 shade here, a little bit gray. But what we would do if we were reconstructing this dentition is we would use shade progression to give a bright, vibrant smile, starting with the central incisors and moving onward to a slightly less vibrant color, and then through either altering the value or the chroma, moving to a canine that transitions the artificial dentition into the natural dentition. So we have to be very thoughtful about this. And then tooth display is, a very interesting thing. At repose, a woman will show approximately 1/2 of their incisor. A man may show only the slightest edge of an incisor. In a full, bright smile, again, we talk about the ideal. The ideal smile today is one in which, and this is for a young individual, where all of the papilla of the anterior teeth are shown and just the edge of the tooth is visible. And it's a good idea to take these types of smile: repose, speaking, and a vibrant smile. Now, the lower lip framing is interesting. The smile line that we speak about that runs as an arc from posterior tooth to anterior tooth and back to posterior tooth is revealed against the lower lip. But the actual truth is these teeth and these incisal edges lie on a flat occlusal plane. the appearance that we achieve in following the lower lip framing is actually controlled by the incisal embrasures, small, medium, large, creating a curve that mimics the lower lip framing. This use of negative space is very important in deriving a youthful smile. Youthful smiles are appropriate in the youngest of people, but may be inappropriate in the reconstruction of a 70 or an 80-year-old individual. So, tooth dimensions do affect tooth display, but gingival architecture also affects tooth display. And sometimes with gingival architecture, we can have imbalances or we can have excessive gingival display. A very classic paper that everyone who's done any prosthodontic training would know is the paper by Vig and Brundo in 1978. Others have studied this, and there's some very good papers here that are more recent. But when we think about tooth display, what they say is for males, the average male will show 1.9 millimeters of maxillary teeth and 1.2 millimeters of mandibular teeth. That's just a small part of the tooth. Women show much more of their maxillary incisors, about 1/3 to 1/2 of the tooth, and only just a glimmer of white appears when they are smiling. As you grow older, as you look through here, you can see that there is a reduction from ages 20 to 25 to ages 50 to 56 in the maxilla, where in the lower arch, this is average of males and females, there is an increase from about 1/4 to 2/3 of a millimeter to about 1.5 millimeter. So we see a marked reduction in the display over age of the maxillary teeth and a marked increase in the display of the mandibular anterior teeth. So on average, the mean visible tooth at rest, maxillary is about 3 millimeters, mandibular about 1.5. And it's critical to evaluate the amount and location of tooth display while patients rest, speak, and smiles. This was published by Halpern in his textbook on complete denture construction. But it's also become very popular today because people use videography to capture their patients speaking, and this can be valuable in transitioning information to a laboratory. I joke around that, we get our social norms from television now, so this is the late night host approach, the 3 late night hosts on American television, Stephen Colbert, Jimmy Fallon, and Jimmy Kimmel, and you see they all smile brightly, and when they're smiling, these men are showing almost their entire incisor. You'll notice that he has good smile line. He's a little bit older, a little flatter. Jimmy Fallon has this dynamic smile again with the gingival embrasures following this big smile. And Jimmy Kimmel, he's got an inverted smile line, but he still has this bright dynamic smile showing the variation. We can also look at the late night guest approach, and you can see Jewel. She has a beautiful smile, even though she has a displaced lateral incisor, because the midline, the occlusal plane, the macro aesthetic principles are all in good shape. Her centrals and her canines are symmetrical. Taylor Swift has this big, bright smile that is very typical today, almost class 2, showing, again, all of her incisors and a big smile. And Adele, she also has a very nice smile, but good symmetry and the axial inclinations are aligned. She has this dynamic smile again with the incisal edges. But if you'll note, her midline is a bit off, and she has a slight asymmetry of her central incisors that don't affect the natural beauty of her smile. So by looking at these pictures, one can begin to appreciate how the macro aesthetic determinants of a smile really drive beauty. Moving on from more, for me, the most important book I ever read was a book published in 1981 by Scherer, Kropp, and Belzer. And Urs Belzer, as a young faculty member in Zurich, I believe, published a drawing from 1979 that talked about 12 aesthetic principles. And he talked about symmetry, tissue contours, tooth features, and negative space as being interesting components of what could be a very, very important set of objective criteria for dental aesthetics. Now, he moved on to publish actually 14 objective criteria for dental aesthetics in the Magne and Belzer textbook, Bonded Porcelain Restorations. It's represented in chapter 2, and I believe that there has yet to be written anything better on objective criteria for aesthetics than the Magna and Belzer publication in 2002. I'm going to go through these 14 criteria with you one by one, but they're just not textbook information. These 14 points, in addition to my MVP, midline occlusal plane and vertical dimension of occlusion, form the 17 points of a comprehensive aesthetic diagnosis that every patient seeking the treatment of any single tooth requires before beginning therapy. Every patient who undergoes aesthetic treatment of even a single tooth requires that we observe and evaluate and communicate these 17 aesthetic parameters, the 14 objective criteria here and the 3 MVP criteria I mentioned earlier. Gingival health is very important to aesthetics. This is a patient who came to our clinic with the wrong gingival contours, the wrong gingival health, and this patient was restored, but an unsuccessful gingival appearance, and much work had to be done to create health in this situation. Interdental closure is clearly a distinguishing feature, and I like to use this slide not because it's beautiful, because it's the first clinical photographs I've ever taken, and it was done in my dental school years in the early 1980s when the first tooth-colored composites were developed, and I was so proud to close this large gingival embrasure for this patient who I had done periodontal therapy for. Now, when we think about interdental closures, we also have to think about diastomas. And diastomas bring an ethnicity to a smile that often does not need or require treatment. It is a morphological appearance to a smile, and one does not necessarily have to treat every diastoma, but they are issues and some people will request diastoma closure. This I would treat with simple veneer restorations. This I might ask the patient to consider marked orthodontic therapy. Tooth axis is very important, and you can see how this tooth axis situation is absolutely abnormal and creates a great deal of problems for us as restorative dentists, but I use this to highlight just how tooth axis can be disturbing. However, what's most important about tooth axis is that they are bilaterally symmetrical in an ideal restoration. The balance of gingival levels really is a very important determinant of aesthetics. In this reconstruction, you can see that we've had caries and other issues here, and we took this patient from here to this situation, actually still in provisionalization, as you see here, to balance the gingival levels, requiring ostectomy and gingivectomy or crown lengthening procedure to be able to adjust these gingival levels to provide this patient who showed these gingiva in the smile aesthetics that she demanded. This is another example of where we moved from a preoperative situation where the patient was dissatisfied with her new crowns, had come to me, and immediately I had re-prepared the teeth and changed the contours of the teeth and delivered these 4 crowns, and immediately realized that I had created an asymmetry that was unacceptable to myself. So we quickly refined this, and here, only 4 weeks after a mild gingival procedure, you can see she's still healing, we delivered 1 new crown to account for the change in the gingival contour, creating the symmetry that I think was necessary for the 2 central incisor teeth. You'll also notice how it changes the appearance of the central incisor. This central incisor tooth is no wider than this central incisor tooth. This has a different aspect ratio, height to width, it looks square. This has an increased height to width ratio, and so it looks rectangular. These small 1 millimeter changes in the anterior dentition by altering the balance of gingival levels is one of the strongest tools we have in our aesthetic toolbox. There are basic features of tooth form. They relate to the shape of the root relative to the crown. There are square teeth, there are triangular teeth, and there are oval teeth. One of the biggest challenges with triangular teeth, of course, is gingival embrasures. And one simple thing to do is to try to alter that. It's a very technically challenged process, which requires that we don't involve the soft tissue in ablating this. but we are able to often widen the crown contour, slightly changing the triangular form of the tooth to a more oval or square form to generate the proper contour. You'll also notice that I've not paid attention to the incisal contour of the teeth. You see, square, triangular, and oval has to do largely with the gingival contours. So as we think about teeth, we always have to consider what the gingival complex is. Making changes to the incisal edges of the teeth to change from a square to a triangular to oval is no effort whatsoever, and oftentimes can be done in the context of patient preference. Now, one of the things that happens with our incisal edges is our incisal edges wear. You'll see the posterior bite collapse due to the asymmetry of the extracted teeth in the lower arch and the missing teeth in the upper arch here. And this patient is interested in a comprehensive rehabilitation. There's been a midline shift, but there's also been severe wear. And so the question then becomes, well, what is the shape of this tooth? Is it an oval tooth? Is it a square tooth? And one has to go back. Oftentimes one can look at a lateral incisor in the lower arch to determine what the natural shape of the tooth was. My inkling here is these are rather triangular teeth, and when the gingival health is resolved and there is little inflammation, the true contours of these teeth will be revealed. So one should always account for tooth wear as to what the tooth shape might be at presentation, and think about what the tooth shape should be upon completion. Color is another one of the important factors, and color is not so simple. I think in addition to hue, chroma, and value, the biggest factor we have with color is translucency. We will talk more about this at a later time. But again, the same case I showed you before, moving from here to here was actually a matter of changing chroma, using actually in-office milled crowns. These are Emax low translucency crowns with no veneering material on them. And one can see that we've moved from this very odd over-painted Emax press crown that has no translucency because of all the stain on the surface, from what they had characterized to a canine. What we had done is simply bleached the canines and then went with a lower number crown from a B or a D shade to an A shade tooth. And color is remarkable. These two central incisors were disturbing to the patient. Obviously, they just did not match. For some reason, they were accepted, and I simply removed the crowns and replaced them with two in-office milled crowns. And you can see the translucency here is imparted by micro-layering, which we might talk about later. Color is not always an enemy. This is a patient, as you can see, who is treated for periodontal disease with a recurrent abscess. And while there was health achieved at these teeth, this tooth required extraction. And so the tooth was extracted, and I grafted the socket, and I waited with provisionalization of a 3-unit fixed dental prosthesis for a matter of 4 months, and then made my final impression at 4 months, and the laboratory returned with this 3-unit zirconia prosthesis. Micro-layering was done, and you can see that Mr. Lee Culp's lab did a remarkable job in developing the appropriate aesthetics, near perfect in this reveal. And now you can see that color is not your enemy. And this 75-year-old woman with modest periodontal disease but good control has a beautiful display, a 3-unit fixed dental prosthesis against her natural dentition. It can be done, and it can be done elegantly, as I've shown you. Part of this has to do with the character, and the texture of teeth has to be often very, very carefully managed. Some crowns should be very highly glazed. Some crowns should be polished. Some crowns should have micro texture imparted to them, and other crowns should not. Some crowns have multiple color striations in them, and we'll talk as we go through. But characterization is really what we pay for in an elegant restoration. This is an implant crown that I had made for this patient, and you can see we tried to adopt the texture of this crown, to match the texture of the adjacent teeth, and If anything, it's overglazed, and I probably could have reduced the glaze by polishing it. In this case, a patient came in with remarkable texture to his teeth, and it was really quite challenging to go from the failed tooth to the implant to the final restoration, where we tried to match some of the character in these teeth. Challenging sometimes. It's often not done in the first try. In fact, this was made by a laboratory, but stained and glazed and retextured by myself at delivery. So in addition to surface texture, we have issues of opacity and translucency, a very opaque white tooth. These are very easy to match in a clinical scenario. And transparent teeth are very challenging to match. They often have opalescence, which we'll talk about in a minute, but you see the translucency here. One of the things you see is it's translucent when the patient's mouth is open and you're evaluating this, but oftentimes when the patient closes, the white lower incisors mask this translucency. So one has to be very careful about how one is evaluating this. The other thing that I will mention is that in many, many situations in presentations from laboratory technicians, the very highly translucent teeth lower the value and make teeth look gray. Some of our patients actually prefer a more opaque white tooth than they prefer the highly characterized translucent teeth. More work from Mr. Culp demonstrating this is layered Empress crowns, I believe, the most translucent materials we can, but again, imparting opalescence to the teeth to give it a very natural appearance. Some patients may not accept this highly characterized crown, but some crowns require this to match the adjacent teeth. So when we think about, the next steps, perhaps we should be considering, the relative size of teeth. And here we can see that this is all good. This follows what we are all used to thinking about in terms of the golden proportions, if you believe in this magical number of 1.618 and a diminishing size of the reveal of the tooth from the facial dimension. This has been studied and actually refuted, and it's very challenging. In fact, perhaps a better way to look at this is that the crown, the dimension between the width and the height of each of a tooth is 0.8. So a crown is 0.8 times as wide as it is tall. The lateral incisor dimension is 0.8 times the width of the central incisor. And another little trick here is that you can approximate the dimension of a lateral incisor based on the mandibular lateral incisor if you have no teeth to work with. But relative tooth dimensions are very important. In this full mouth reconstruction, we have lots of problems with relative tooth dimension. They don't match. And one of the things we have to do is adjust the midline occlusal plane and the relative tooth dimensions to work. Now we can use the golden proportion or a tooth proportion constant. And I tend to use this tooth dimension constant to establish my central incisor, then my lateral incisor, and then my canine. So in addition, we want to make sure we use this 0.8 to 1 to 0.8 to always assure that we have central dominance. These are very large lateral incisors, but yet the central incisors show some dominance. And as you can see in this black and white photograph, of a different art case, these central incisors are relatively small in comparison to the laterals, and so the smile is not as dynamic as one might choose when compared to this smile. The next the next item on Belzer's list is incisal edge configuration, and incisal edge configuration has to deal with function, the way teeth move in occlusion and wear is acquired over aging, but also has to do with your artistic sensibilities. And I think this display of teeth is absolutely beautiful. One of the reasons that this is so attractive is there's a great deal of symmetry driven in this smile. First, the embrasures are symmetrical. Secondly, the long axis of the teeth are symmetrical. Third, the contour of the central incisors are symmetrical. And so when one wishes to impart just a small aesthetic detail, the curvature here, the softness here, is reflected by the softness here. And despite the difference in the length of the two central incisors in this, we end up with a beautiful appearance and what I consider to be a very artistic display of teeth, not created by a technician, but created by nature. When we come to the integration of a smile, we try to create an attractive and dynamic display of teeth. And as I mentioned before, this is determined by incisal edges and incisal embrasures, or negative space. And as you look at this woman with her big, big, big smile, her teeth follow her smile line, but it is the negative space, particularly here in the canine, that is driving this curve that we see. So make sure that you try to follow the lower lip line and try, as we illustrated with one of our talk show hosts, that we don't have that inverted smile. Oftentimes that inverted smile has to do with function and occlusion, and it would require orthodontic recontouring. Simply lengthening these central incisors may not be coincident with function or the longevity of the mandibular teeth. We see this gull wing form where this would be the embrasure at the canine and then dipping down to an embrasure of a premolar. It's often easy to accentuate this by creating a larger embrasure at the distal of the canine, which you can do. So again, when we think about creating the smile line, we're looking at the progression from the central incisor to the canine. And again, here in the distal, you can see even going further. Finally, smile symmetry is so important. I've mentioned it in terms of the importance of axial inclination, gingival levels, and embrasures, all the things that we really never think about. This patient we treated maybe 20 years ago with dental implants, and she came with a maxillary partial denture versus implant prosthesis in the lower arch. And you see, the real issue is that she has no symmetry whatsoever. Her natural teeth are not coincident with her midline. Her clasp is the real giveaway. If this tooth probably were not here, her aesthetics would be reasonable. However, you see the negative space is also not symmetrical. So driving smile symmetry is one of your strongest tools, but it begins with knowing where the occlusal plane is and where the midline is, because without the occlusal plane, the midline, and of course the vertical dimension, it's very difficult to begin to apportion parts of aesthetics to the patient without that backdrop. Here you can see we've gone and restored the patient with an implant dentition, and we have 8 implants in this maxilla supporting 14 crowns, and now the midline is coincident with the midline of the face. It does not match the midline of her acrylic hybrid prosthesis, but that's inconsequential. The long axis of the teeth are symmetrical from shared pair to shared pair. The embrasures are symmetrical and again increasing from one to the other in an ideal textbook fashion. And you can see the negative space is symmetrical from left to right. She's not smiling large enough to see the symmetry in the corridors, but again, we use symmetry to drive aesthetics. And again, the lower lip line, you see the negative space following the lower lip line. This in an older individual, still working to our advantage. So I have another way of looking at simple aesthetics. Dental aesthetics is actually space management. And I want to suggest in this very simple picture to you that if you can manage the pink space, the white space, and the black space, and manage symmetry, you will have very good success with dental aesthetics. And whenever you look at an aesthetic problem, you should always think about pink space, white space, and black space. In this case, all we did was change a single crown. A very simple procedure done in our office where we're able to mill this restoration for this patient and deliver this beautiful result. Now, one of the things we did is we did change the axial inclination of this crown. That's managing the white space. But what was important was to remove the discrepancy. And the discrepancy is very simple. I have a very simple, if I can move the slide forward. Dental aesthetics and space management really is following 3 rules. The first rule is white always is adjacent to pink space. Black is always adjacent to white space. And black space can never be between white and pink space. And if I go back to this slide, you'll see that The aesthetic challenge here, aside from the long axis of the tooth, the glaring deficiency is we have black space between pink space and white space. This is the cue that something is not healthy, because our projected image of health is pink against white. Our projected image of health is pink against white. And this is a cue that something is incorrect. So if we can manage pink space, white space, and black space, thinking about symmetry, which I don't show here, white against pink, black against white, and black is never between white and pink, we can derive very strong aesthetic outcomes. Now, what I would like you to do is use this knowledge. I want you to understand and remember these 14 objective criteria. I want you to optimize these criteria to meet your plan. I want you to perform procedures to promote tissue health. And then you just go ahead and you fabricate your restorations that integrate the aesthetics and then maintain this with appropriate hygiene. So let me give you just a very quick example, and then we'll go into more detailed example. Individual comes in, we have to restore this patient. She has a provisional crown with a dental implant. And we go through this from the beginning, apply our 14 objective criteria. If we only restore the implant tooth, she will never achieve aesthetics. Looking at this tooth as the prototypical tooth for her, her tooth has an oval shape, if you will, with a very sharp S-shaped curve to the distal aspect. And what we can do is we can actually restore this patient to a very, very attractive view with two central incisors that show symmetry of the gingival levels between this and the tooth. And you may now only begin to recognize that what's interesting in this individual is she is missing her lateral incisor. This is a canine tooth, this is a premolar tooth, and this is her canine. So we can drive aesthetics using our fundamental parameters to achieve challenging results. I showed you this case before looking at space, but how would you complete this diagnosis? What are the relative tooth dimensions again? How do we manage them? We can use textbook information to help us. What's the issue with the balance of the gingival levels? Do we have a problem here? Yes. For us to make a beautiful aesthetic outcome, we are going to have to figure out where the occlusal plane, the midline is. The vertical dimension in this case is fine, but where will we place the teeth and how will we manage the gingival levels? Because if we can begin to place our tooth axis and our gingival zeniths in the correct place, then we can define symmetrical tooth axes. So we define this in our provisionalization stage. We use central prominence here, certainly expanding the central incisors, moving the midline, and then adjusting the gingival levels. And as she smiles, you see she shows her papilla and just barely not the tips of her gingival zenith. We have increasing gingival embrasures going across here. And now I think you'll agree that we've managed this appropriately. We reevaluate in the provisionalization stage, midline, occlusal plane, long axis of the teeth. And now we can come and finish the case, very carefully managing our gingival tissues. Again, adjusting the soft tissue where necessary here. She has a lot of keratinized tissue, deep probing depth. It's very easy to just subtract this, so we can manage very carefully. And then as we do this management of aesthetics to match left and right, we're able to deliver the final restorations in a manner consistent with our plan. Long axis of the teeth, helping to drive the symmetry. The midline is on, the gingival levels are nice. And again, you see the dynamic smile for her with a deep embrasure here, matching on the other side. And choosing the very opaque, this has to do with the style of porcelain the technician used, which happened to be the patient's husband, which did not allow me a choice here. These are very opaque, early 2000s ceramics, which unfortunately limit, I think, the aesthetics of this case. But if you look left and right, I'm sorry this has moved, but we were able to make this symmetrical. There we go. And from start to finish, you can see that by controlling the 14 objective criteria, we're able to move from this to this in a very direct manner without guessing or even changing what we had done from our wax up. Now, this is a dissatisfied patient who did not like her two central incisor crowns. And there are many errors that are minor, and they're all identifiable using the 14 objective criteria. Primarily, what we found was there was asymmetry in the gingival form and the location of the gingival zenith between the right and left central incisor. And this changes the tooth shape and the long axis of the two central incisors. And so when we look at this, you can see she has one central incisor going one way, another central incisor going the other way, and marked gingival asymmetry. So we have a square central incisor and a rectangular central incisor, more clearly seen here. She has reasonable gingival health, and we're going to remove these two crowns. So before we remove anything, we want to understand the biological width around these teeth and understand just what we're dealing with, whether the probing depth's 3 or 4 millimeters here, 3 millimeters here. So comprehensive aesthetic diagnosis is assisted by excellent study casts. We have a midline that's coincidence, an occlusal plane, and then we start to see some of the challenges with two teeth of different size. They're actually the same width, but they look asymmetrical because of the aspect ratio, and it's all because of the contours of the gingival levels. Going through our 14 objective criteria, we begin to understand what is wrong with this tooth. So looking at this again, here's my occlusal plane, here's my midline. I marked the gingival zenith so you can clearly see the discrepancies. I demonstrate that we do not have any issues with the occlusion. And now we can move beyond the basics and proceed to our treatment. So we perform a diagnostic wax up, we move the gingival margin, and we take a shade to show you that she has a shade C2 or an A2. However, these teeth are probably more in the C shade, but these teeth are actually not what she's going to want. She's going to want us to blend this to a more of a C1 color. And so when we think about the translucency, this is not monolithic. She does have translucency here, and we're going to have to account for this. You can see her natural tooth translucency is not accommodated by these crowns. So how will we make these crowns? We're going to mill them in the office, and we're going to use Emax as a material. So we begin by removing the old crowns. This preparation is acceptable, and this preparation scares us, but the tooth is vital. And now when we look around, we can see that we've removed the crowns without damage to the soft tissue. These teeth are absolutely symmetrical. This tooth is wider than this tooth because it's prepared more coronally along the root. And so we have to think about tissue management. So again, when we probe this sulcus, we think about having 3 millimeters or 4 millimeters. And the question is, how can we manage this in a direct way? So when we think about this, you can see this 1 millimeter of tissue has changed the shape of the central incisor. So what we've chosen to do is we pack a cord very aggressively here, and actually packing the cord atraumatically, and now you can see the margin that has to be displaced. But we also want to remove about 3/4 of a millimeter of soft tissue. So using an inverted bevel, internal bevel gingivectomy against the root surface, we remove enough of the tissue to match the designated temporary crown. In doing this, we now expose our crown margin. We go forward, placing our new margins, as you can see around the one tooth, more reduction on the lingual, and again, packing a cord and controlling our margins so that we're able to move directly into the final restoration. Here you can see the cord packed in our new margins. And so we're able to look at our reduction control. This is the wax putty index from our wax up. And then how would we do this, digitally or virtually? Well, I'm not going to be able to take a good digital impression that deeply, so we will be taking an impression of the teeth and then scanning the model. So we go from we are going to be doing that. So provisionalizing this patient is going to be very important for us because we need to adjust and manage the tissues. Here you can see we've made a simple thermoplastic shim, but a better way is to use a putty index that captures the details of your wax up. And the way we provisionalize this is we use 2 colors to adopt and adapt that translucency. The first incisal layer and facial layer is an A1 or a B1 material. then followed here by a darker A2 color or C2 color. And then we really like bisacryl materials for this, and there are many advantages, as you see here. But the disadvantage is it can be rather brittle. So we take these materials and we put the material on the margins, we put this in here, and we cast this. After a minute and a half, we don't remove it, but we take a blade and we start trimming the excess. And then we refine the margins if necessary and pick up these nice sharp margins in our impression. And then after careful execution and cementation, we deliver these temporary crowns. So our patient returns a week later, and you can see that we have some nice healing going on, a very minor procedure. And now we're ready to really proceed and move forward. Our provisionals have given the patient a view of what our new crowns will look like. We see where the gingival levels are. And again, looking very closely at these tissues in the provisionalization stage, I think we're in a very good position to begin to move forward. So what we're going to do is then take a look and see that the tissue responses do define the provisional restoration outcome. Epithelialization, the absence of bleeding after a week, really shows how remarkably quick this heals, and now these tissues can be adapted. Now, we've copied our provisionals in a scan, and we move to our final impression. Again, we scan the model and we see our margins. And so we can go ahead and go from virtual to digital, and we can mark our margins and design our crowns, and in this case, perform a cutback design because we need to incorporate the aesthetics. And we can go ahead and mill these crowns, and then simple micro layering in our office, we're able to add the T1 material required. You can see the contour on the lingual has not been altered. This is work we're able to do. And again, our incisal edges of our wax up match the incisal edges of our ceramics, so there won't be any adjustment when we get to the clinic after we've stained and glazed these crowns. And now they can be etched and they can be brought to the mouth, and moving from our provisionals to our final restoration. So in-office milled crowns of the appropriate base shade with translucency that matches very nicely the adjacent teeth, giving us the aesthetic outcomes we're looking for a single tooth, moving from here to here. The trick here was to define what was wrong with this tooth. And it's not that they're the wrong shape or the wrong color, it's that there are fundamental things wrong with them. And we talk about tooth axis, we talk about the dimension of the tooth. We don't necessarily worry about the shape of the tooth, but unless we diagnose this as an issue of gingival contour changing the aspect ratio of this central incisor, we would have never matched these two teeth. I'm going to show you very quickly another case where this individual had come and he had been treated in another country, and he was concerned about the health of his teeth because there were bleeding on probing and he had a foul taste in his mouth. He wasn't concerned about the aesthetics, but you can see that these ceramic crowns don't necessarily match. This is just characterization from a typodont. And marginal discrepancies being what they are. And so again, he's got some color problems that we're going to deal with. And we go ahead and again remove the crowns. And now you can see that there's a lot of hemorrhage, and there are no real issues with the preps, maybe under-prepared in some locations. And again, a lot of cement between the margins of the crowns and the teeth, so they did not fit well. And when we pack our cords, we see abundant cement here. And now this all has to be defined. And then what is possible? Well, what we're able to do is pack our cord, refine the preparations, and then using the same technique I showed you before to cast our two-layer provisionals, and then able to lay in some colored material here to give him a little bit better aesthetic characterization. We probably need to round off that corner, but you can see the really hemorrhagic tissue here that's really puffy. And we take our shades, very first visit, to make sure we know what we're going to be able to design and mill for him. And we send him on his way. Now he returns a week or two later, and here are his provisional crowns. And if I go back, you can see that the tissues responded very nicely to the new margins. And so I think it's time to move ahead with the restorations. And so again, we remove the provisionals where you can see the nice tissue healing here. It's only been a week or two. We're going to pack our cords, and then we're going to directly scan and mill to in-office crowns. And the outcome here is pretty close. You can see that we've added the white staining internally here by creating grooves in the crowns and layering the glaze and then firing it again with glaze to give him healthy tissue and two crowns that match aesthetically to what he needed. I'm going to close here in the last minute or two and show you where we are with digital technology, and again talk about compromises in aesthetics. The single central is a big challenge. It's challenging because we have to have symmetry, the gingival contour, the tooth morphology, the color, the translucency, and the surface texture here, which is very challenging. It's very subtle. And so he has a subgingival fracture. He was seen immediately. I chose not to extract the tooth as an implant, but rather send him to the endodontist. The subgingival fracture proceeds almost to the crest of bone. And so the potential risk of crown lengthening are obvious, because if we do a crown lengthening procedure, we'll be moving the bone 1.5 millimeters, which would result in recession, and I'm afraid that we would have 1.5 millimeters recession. Now, what that would do is create a very long central incisor that is not symmetrical with the other. So to avoid the gingival asymmetry, I chose to carefully use the fracture line as the margin here and not do the crown lengthening procedure. So I've glued the fractured fragment back on as a temporary after endo. And now he's going to come to the clinic, and you can see he's done very well for 3 weeks. And look at the beautiful micro texture of this, very difficult to replicate. And now we've got our shade selection. You can see very light teeth, a bleach shade versus a B1 shade. It's going to be very challenging to match these teeth. And we take our preoperative scan. You see the endo, the glued fragment. And now he's been anesthetized. And I have gone and placed my depth cuts, my interproximal slices, and then packing cord and refining the preparation. And again, you can see some of my composite remains here from when I've glued the tooth, and you can see the margin dip down below here where the fracture line is. So when we think about the scans, you can take a look at the scan and you can begin to appreciate what we've done here. You can see the natural tooth margin and you can see it very nicely. You can see the cord packed below here. And even better in the black and white image, you can see that we've captured our margin. This is from here to here is the fracture line of the tooth that we're using as the margin. And we're going to avoid at all costs any crown lengthening procedure. So we get our margins carefully adapted, keep our margin manageable. We're going to use a 2-cord technique, pass the first cord before the preparation, burrs never touch gingiva, directly manage any hemorrhage, and we pack the second cord to expand the sulcus to allow us to use our imaging. And we walk away and let time expand the sulcus. You have to see your margins to be able to scan them. So the scan that I showed you is sent to Mr. Culp's laboratory, where he immediately designs the tooth by cloning this tooth and flipping it. It takes just a minute. Here's the color that we've chosen in real time. And then Mr. Culp, in the next day, returns to me this very beautiful Emax crown. And again, you can see the small surface characterizations here trying to mimic what we have here in a very light way. Some little decalcification perhaps, trying to mimic that in a very nice way here. So here's the natural tooth. Here is the crown a week after delivery, showing that we're able to really match the contours of this tooth. And the selection here was to maintain gingival levels. So let me conclude. There's some steps that you have to use in any aesthetic case. I've shown you simple cases today. We'll come back and talk about fixed prosthesis in the anterior and implants later. But identify 14 objective criteria and the 3 MVPs that are so important in understanding how to build an aesthetic case. Optimize the criteria to meet your plan. Find which of the criteria are offensive and fix only those criteria. Perform all procedures to promote tissue health. Fabricate restorations with ideal materials, integrate aesthetics to the face, and then protect your work by having your patients come for regular hygiene. Well, my hour is up. And Uvo, it's been a real pleasure to work here with you today. And I hope that what I've shared with your 80 participants has been of some value.
Thank you so much. Thank you. This is an amazing lecture. I mean, I think this is, first things first. These are first things. Before you see your patient, it gives you a very good perspective. Do you have any questions out there? Please type it in the chat. I have a question here, and the question says, what software, digital software, do you use?
All kinds. I grew up in the E4D world, and I still love the E4D Emerald scanner, and I think their tooth designing software is some of the simplest for chairside design. 3Shape is always on the leading edge of scanner technology. Some companies are keeping up. Of course, PrimeScan is a phenomenal scanner. And the biogeneric software in the Dentsply PrimeScan system is really outstanding, but it's linked to their mill. If you have a 3Shape scanner, you're going to have to figure out a way to link it to a mill. So in-office milling, you really have two strong choices. You have PrimeScan and you have Emerald linked to the E4D mill.
Okay.
There are new mills coming. Ivoclar has their P1 in-office mill, and that can be linked to a 3Shape scanner in clinical software. So we really have lots of choices today.
Any more questions out there? Dr. Cooper is going to be back hopefully in the next couple of weeks. We have three more topics that he will be graciously willing to address for us. And if you do have any particular topic in mind, please send me an email and we will get it out there. If you do have any, Dr. Cooper, are we able to get post-test questions later on from your presentation?
I can get you post-test questions, yes.
Yes.
So you and I'll connect later this weekend, and we'll figure this out. We will.
Okay, thank you so much. I really appreciate you. Thank you very much. Thank you so much. This has been, historic for us. What started as one.
Ugo, I'm going to interrupt you. You need to be congratulated because what you're doing is just remarkable. And I think the world needs to recognize really what you're doing here. This is phenomenal. Thank you for letting me be a part of this.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator